Hello, good morning. It's a great honor and a privilege to be here with you in this beautiful big Congress in orthodontics. I'm a plastic surgeon, and before many of you start asking, what am I doing here? I would ask you to listen to my story, because I have profound respect and admiration by all the work you guys do. And the only reason I'm doing what I do is because I didn't have no one to do nasovelar molding to me. So back in 2010, I was totally obsessed with NAM because I was looking at what I was doing and results were not that good. And then I look at NYU result and I said, you need to do NAM. So I received a scholarship, I went to the US, and I spent half of the time I had with the dental teams at Baylor, at SickKids, at NYU, Children's Hospital of Boston. And I was so stubborn that at Baylor they said, okay, sit down, we will teach you. And I did one NAM device myself, which I'm very proud of. But NAM is not for surgeons. NAMS requires a dental specialist with great expertise. So I came back to Brazil. I was totally frustrated until Dr. Monasterio presented his case series using a hook made with a paper clip. And then I said, this is something I can do it. So that's what this led to what we have today. I don't have experience. I never did a surgery on a patient that was pre-surgery treated with NAM. But I believe with all my heart that is still the best option for pre-surgical orthopedics. And the reason for that is it's beautiful how you guys can have absolute control over the segment's movement, because we don't have this. This is random. We keep looking, but we don't have this control. And having this control, I think it's special. Anyway, if you don't have experience with pre-surgical orthopedics, with NAM, if you don't have the facilities, if your patient cannot keep coming every week, or if you have a busy schedule, you have patients every 20 minutes, this is something easy, this is something simple, it's inexpensive, and even the surgeon can do it. So, so I hope you all could enjoy this hands-on session. I'm really nervous to be here under your judgment, but I would like to have your feedback, okay? So for me as a surgeon, I can say that cleft lip and palate still challenge even experienced surgeons. So for unilateral clefts, despite well-executed surgical procedures with very nice initial postoperative results, there is sometimes, after some while, the dropping of the nasal tip. And this nasal asymmetry, especially in the soft triangle area, greatly compromises final cosmetic results. And despite the surgeons striving to perfect the procedure, thus far it is still not possible to predict who will evolve with poor or excellent outcomes. For bilateral deformities, surgical challenges are related to the shortness of the columella height, with a nasal tip tethered to the prolabium and the protruding deviated premaxilla, which determines, for example, if surgical procedure can be performed in 1 or 2 states. Thus, pre-surgical infant orthopedics is used to reduce cleft severity and improve nasoform symmetry to ease and improve the results of the primary operation. In the early 90s, Dr. Grace and Dr. Figueroa pioneered pre-surgical nasovelar molding. And today, because of long-term benefits to the patients, this presurgical treatment has been incorporated as part of the cleft treatment protocol of many centers around the world. There are some few complications that can occur, but what is important, especially in low and middle income countries, are the difficulties that can be associated with its use, such as the necessity of weekly appointments, which can take up to an hour, and a complex system of surgical tapes and elastics to hold it in place, all of these representing high costs of treatment to a public health care. Looking for alternatives, Monasterio designed an alternative method using a single paper clip. In 2013, he published the results of a comparative study between this new device and the non-Grayson, showing that for both the alveolar gap and the nose, results were quite similar. Inspired by this, but mainly because we did not have access to nasoalveolar molding, in 2014 we started a treatment protocol for all newborns with complete cleft lip with or without cleft palate, in which the device is installed at the initial consultation. Parents return to clinic every 15 days until they feel confident, and thereafter once a month until the surgery, which occurs between 5 to 6 months of the baby's age. Therefore, observe how the simple method can improve the outer nasal anatomy and how it can reduce the size of the maxillary cleft in patients with complete unilateral cleft lip and palate. In bilateral clefts, verify how far the premaxillar retraction can be obtained and how soon, within 15 days of use, these results can be noticed. For asymmetrical cases, you can start using a unilateral elevator. Then, when it's overcorrected, you may change it for a bilateral one. Alternatively, you can use a bilateral device with a shorter leg at the wider cleft side. And as you can see, significant improvement regarding symmetry can be obtained. Starting in 2014, 261 patients have been successfully presurgically treated under this protocol, which represents approximately 40% of our primary cases receiving presurgical orthopedics. As for any methods of presurgical infant orthopedics, there are many concerns about its effectiveness, its benefits to final cosmetic results, its burden of care, and finally, its impact on the long-term facial growth. So to analyze the PSIO effectiveness in unilateral clefts, we have been measured the nose width ratio and the columella angle. We have established a grading system to rate severity and outcomes. And by doing that, you can see that severe deformities can be significantly reduced with strengthening of the nose. In our initial sample, the mean age of PSIO start was 27 days. 77% were initially rated as severe deformities, and 70% of them were complete cleft lip and alveolus, lip and palate. After presurgical orthopedics, we can see that there was a significant reduction in severity. And when you analyze the PSIO outcomes, we can see that in the poor outcome group, 70% of patients had complications. 70% of them started PSIO after 1 month of age. But if you look in the excellent outcome group, you can see that 37% started PSIO after 1 month and 12.5% started PSIO after 1.7 months. So 1 month for us doesn't seem to be a cutoff for effectiveness. For bilateral clefts, the ratio of nostril height and width, as well as the ratio of nasal tip height and width, as proposed by Chang, has been measured. And once again, you can see that there is significant strengthening of the nose. To analyze the cosmetic benefits of using this device in unilateral clefts, we compared 112 patients who were presurgically treated to 62 patients who are not. Both groups were treated during the same period by the same surgeon using the same surgical technique. And by using classification system, to focus on rating post-surgical nasal morphology, which for the surgeon I think is the crucial point. We observed that, in contrast to 80% of excellent outcomes in the PSIO group, such results were not found in the control group, for whom any sort of nasal asymmetry was at least threefold higher. This was statistically significant, and through the calculation of the odds ratio, we observed that if you use presurgical orthopedics, the chance of having an excellent result is 6 times greater. When we compare the PSIO outcome to the final cosmetic outcome, we observe approximately 65% of correlation between the outcomes. But in 30% of the patients, the post-surgical result was better than the PSIO outcome, which we do believe is due to a not so great reduction in the alveolar cleft size, but an efficient remodeling of the cartilage. For bilateral clefts, we separate two groups, those with symmetrical deformities and those with asymmetrical deformities. In the symmetrical deformities, 54% presented with a prominent premaxilla, and in our protocol, prominent premaxilla is treated by lip adhesion. But by doing presurgical orthopedics, it was possible to retroposition the premaxilla and thus avoid lip adhesion in 63% of the patients, and 75% of the patients started PSIO after 1 month of age. In the asymmetrical groups, all patients were treated in a single-stage surgical procedure, but as a cosmetic benefit, it was possible to avoid the usual pterygium incision in 45% of the patients. This is a very simple technique. The nasal elevator is customized using stainless steel wound wire, covered with Teflon tape, and for lip taping, we use kinesiology tape. In our institutions, that the treatments carry out until 5 to 6 months of age, the mean cost per patient is $30 to $50. And the most expensive part is the hydrocolor patch layer. As complications, the most common complication is skin irritation. That's usually happened to reaction to the taping. Intranasal pressure sores, notching in the alar rim, and the creation of a meganostril are other potential complications. But something I think is exclusive of this technique and different from them is the collapse of the lesser segment that happened in 10% of the patients. Finally, to analyze the impact of using presurgical orthopedics under the long-term facial growth, patients were submitted to intraoral scanning, and their inter-arch relationship was blinded evaluated by 3 experienced orthodontists using the 5-year attack index and the 5-year bilateral yardstick. So as you can see, for patients with complete unilateral cleft lip and palate, there was no differences between patients receiving or not receiving PSIO. For patients with complete cleft lip and alveolus, the same happened. And for patients with complete bilateral cleft lip and palate, we didn't have a control group, but comparing our sample with the centennial sample at the same age, we can see that there is no differences between patients receiving or not receiving PSIO. But to analyze this treatment with other PSIO methods, we recently conducted XTX research involving 5 centers and 6 samples. 2 of these centers used Nan-Grayson, 2 of the centers used Nan-Figueroa, and 2 of the samples were alternative methods. 25 patients from each sample were randomly selected from the database, and these photos, pre and post photos, were measured and analyzed, and we did not find any differences related to the method that was used. Of course, there are several limitations in regards to these study designs. So this year we are starting an education and training program involving 7 reference centers in Brazil. We are now calibrating PSIO outcomes and how to document outcomes, and thus far we have 36 entries in the REDCap database. So if it works, next year we may start a prospective, multi-center, 8-year follow-up study involving these 7 centers, 9 samples, where we will compare patients receiving or not receiving this presurgical infant orthopedics method. So observe that through this simple method, severe deformities can be significantly improved. Important nasal deviation can be minimized. Concave cartilage can become convex. But what we really want to show you is that cosmetic results can be improved easily with low costs and few medical appointments. For complete bilateral cleft lip and palate, observe that pushing the nasal tip forward and pressing back on the nasolabial fold results in gradual tissue expansion and lengthening of the columella. At the same time, the domes of the lower lateral cartilages are brought together in the midline. And by retraction of the premaxilla, the usual 2-stage surgical repair can now be avoided without compromising good cosmetic results. Complete bilateral clefts with asymmetry and a prominent premaxilla can become more symmetrical and easier to repair. And bilateral clefts with an incomplete side may have the nose treated without the usual Tojima's incisions. So how do we do this appliance? This is very simple. You need these 3 pliers. The 139, the 410, and the hard wire cutter. We use 0.7 millimeters stainless steel 1 wire. We use the 0.95 plastic tube, a Teflon tape, 3/16-inch diameter elastics, kinesiology tape, micropore, and extra thin hydrocolor patch layer. So very simple to do it. For a newborn, you can use 5 centimeters of this wire. You put the tube and then 80 millimeters from one of the ends. Using the most distal part of the 139 plier, you do a bend and creates a handle. You move, you hold the handle with the 410 plier, and using the most distal part of the 139 plier, you do a little bend in the distal part. Then you move caudally the 139 plier and use the middle portion, you do a second bend. That is between the first one and the end of the handle. You move caudally again, and using the proximal part of the 139th plier, you do a 30 bend. So you have 3 bends. You can soft the rest of the wire. Then you do a distal loop, and then you cover with Teflon tape. In accordance to the deformity of the size of the baby, you can customize the size and the angulations and the width of the base. So if you have, for example, a very wide deformity, you can start using an elevator with a wider base. And then as it gets reduced, you change it for a smaller size. At first, you may think that our device is pretty much similar to the Dynacleft device, but the fact is that they are not, and there are key differences between them. The first one is that in the Dynacleft, in the monasterial device, it improperly activates in the alar rim rather than the nasal dome. So this is something not desired. Because it concentrates forces on the alar rim in direction to the forehead, you have just this vector of traction. When we do in our device, the 3-band system, we create a swan neck shaped device, and when we activate it, it first brings the nasal elevator forward and then upward. So you can bring the tip forward too. Another difference is that the Dynacleft or the monasterial device, it's really hard. So if it's overactivated, it's common to have impingement in soft tissues because of its hardness. And it also precludes the treatment of bilateral deformities because we just have a unilateral device. So our device is covered with hydrocollar or the plastic tube, and so it's much more softer. But the main difference is that it's anchored underneath the dome. Its delivery is very simple too. So one thing people need to have in mind is that the taping and the hook, they work together all the time. They should work concurrently. So the tape brings the non-cleft side to the midline, and the hook balances this movement, also bringing the tip of the nose to the midline. You start applying. You need to start applying the hydrocollar patch layers to protect the cheeks. And then we start doing the taping. You should always start the taping from the non-cleft side to the cleft side. And the length of the tape is from the outer corner of one eye to the other, and the width is from the base of the nose to the vermilion. We always start installation from the non-cleft side. So we apply the kinesiology tape here, and we do not stretch it. Then we approximate, with the other hand, we approximate the other cheek, we stretch the tape, and then apply to the other side, to the cleft side. How much we need to have this approximation of the cleft edge, and it should be a little bit tight here. So we concentrate the force on taping first. After we finished the taping, we start installing the nasal elevator. And so we cut 2 pieces of micropore, a bigger one, about 4.5 centimeters, and the other with 2.5 centimeters. We make a, yes, we take the larger piece and we leave the glue to outside and make like, and then you put inside the elastic. We should always start, include we insert the elevator 3 to 4 millimeters inside the nose, medially, closest to the columella, and the vector of traction is slightly diagonal to other than the non-cleft side. We should not put strength or too much traction in the nasal elevator. It's minimum. It's just what is enough to level the rim. Never more than that. So you should pay attention so that the device would be applied under the nasal dome. So take care to avoid lateral dislodgements. Another thing is that the axis is oblique to the non-cleft side, never vertical. And the device can touch the tip of the nose, but it can never crush it on the soft triangle area. So we have to pay attention to these more common mistakes that are a long, thin, and loose taping, the lateral insertion of the nasal appliance, and the vertical axis. Why do we do this way? We didn't take from our mind, we learned it from NAM. So in the NAM Grayson protocol, the nasal stent is all inserted when you have the approximation of the segments and a reduction of the cleft to 5 millimeters. They do that so that if you start stretching the nasal and the segments are too far away, you will have mega nostril. And mega nostril is too hard to fix surgically. So we do the same thing in this protocol. We first work on the taping, we bring the segments together, and only when the segments, with minimum tension on the nose, and just when the segments start coming together, we start stretching the nose. The same principle. Another difference is that the NAM, the vector of the NAM is upward and forward. That's where the nose should go, upward and forward. But when you use the Dynaclef, the vector is upward and backwards to the forehead. The nose shouldn't go to the forehead. You get like the nose like this way. So by using the three-band apply, yes. We can have the swan neck shaped, and this, when you activate the swan neck, you put forward and then to the forehead. So you bring a little bit forward the nose, because that's the place for the nose to go. They should always work concurrently. If you have a lip tape, it will not work. You should have approximation of the edge to counteract the lateral muscle pull, and then you remodel the cartilage. We want remodeling. We don't add mega nostrils. They should always work together. So the correct to use is this. The length of the taping is from the out corner of one eye to the other. The taping width is from the base of the nose to the beginning of the vermilion on the non-cleft side. You start the lip taping on the non-cleft side without traction on the taping. Then you approximate the cheek on the cleft side, and here you put traction on the cleft side. You insert the nasal appliance medially, closest to the columella, in an oblique axis, with minimal traction to elevate the nose. So it's a very simple method, but you should keep this in mind. The taping should approximate the cleft edge with traction on the cleft side, minimal traction on the nasal appliance, just enough to level the rim in an oblique axis. Always the same. Initially, you need to have the cheek, approximation of the cheek. And as treatment goes, you can start reducing the inclination of the axis. So this is the summary. Concentrates the treatment on taping initially, because will bring the segments together. So it's strong tension on the taping with minimum traction on the elevator and oblique axis of traction. Then when segments start moving, we keep the strength on the lip taping. We increase a little bit the tension on the nasal elevator, and we keep the oblique axis. Segments start coming together, you start releasing the taping. So we start losing it here, we start working more on the nose, and we reduce the angle of inclination. We got the final results, we just want to keep it until surgery. We just release the taping, just keep a moderate traction on the nose with minimal inclination, because then you don't have so much deviation. During maintenance, you should take care not to crush the tip of the nose. You can adjust it very simple just by bending and changing the angulation. And when the baby gets 3 to 4 months of age, parents start complaining they are taking the device all the time. So we can use this little stripe of micropore to the nasal dorsum, and it will keep it in place. Because our surgical protocol is a little bit later. So common mistakes are this: crushing the nasal tip, a loose traction on the nose, a short taping. You see, it's not approximating the cleft edge. The hook's crushing the tip of the nose. This hurts the baby. Again, crushing, taping that is too thin, crushing the tip of the nose. Or in the opposite, too tight. Taping is too tight here, it's too tight and too large. This is also wrong. Lateral insertion, lateral traction, it's not in the right position. So this is all very simple, and now you can start doing. So now we have the hands-on itself. That's very, very easy. Questions? I will show you the video, then we come back to this so we can start doing. This is the third bend. And then you see it's really straight. We just softer the curvature, and with your finger you can do it. This is important not to crush the tip of the nose. Then you have it. Very simple. Here is another video of to install the device. This baby is already under treatment. So here the hydrocollar could be a little bit bigger, I think. The taping should come from one eye to another, and the width from the base of the nose to the vermilion. You start on the non-cleft side without stretching, then you approximate the cheeks, stretch the tape, and put it on the other side. So this is how it should be adjusted. Then you take the micropore and you do like a hole with the glue to the outside. Insert it into the elastic. You insert in the hook. You insert the nasal appliance in 3 to 4 millimeters inside the nose. And take to the non-cleft side. Minimal traction, you see, minimal traction on the nose. Then you put the smaller piece of micropore on top. If you look at the hook and it's crushing the tip, like here it's crushing a little bit, you just check where it touches the nose. You hold where it touches, and then you accentuate the angulation inside. Then you put it, it will be free. It can touch it but not crush it. So now let's do it. So everyone has a kit that has like the pliers and a mold you can take home, and then you have the 5 wires you can bend. Oh no, not the baby's mold. The baby's mold you cannot take it.
Only the pliers.
Only the pliers, only the plastic bag. Oh, the kit has has the pliers, 139, 410, a scissor, a pencil if you want to mark the wire, and a ruler. You have the Teflon tape, that is this yellow thing. And then you have the taping, the kinesiology tape, elastics, and the wires with the tubes so you can bend it.
Congratulations.
Yeah, I think so. It's running. Yeah.